Right, good afternoon, everyone. I hope you can hear me well and see me quite clearly. So welcome to this introductory webinar for the Clinical Skills Assessment Exam, or the National Clinical Assessment Exam as set by the UK Foundation Programme Office. My name is Dr. Karam Singh, for those who are not familiar, and I've been running preparatory courses for this particular exam since 2015, having been someone who's taken this exam in the past. I've been running courses for this now for about a decade, so I'm in a good position to try and give you all the knowledge, all the wisdom you require to successfully get through this exam. Just to give you a bit of background about myself, so I work in the central Midland area, a city called Birmingham, and I work as a GP at the moment, and also in the capacity of a medical registrar. So I've got knowledge of both hospital work and primary care and general practice, and I've been teaching students for various OSCEs since for at least about 10 years now. So very well seated to be able to help you all successfully navigate through this particular exam. So the Clinical Skills Assessment Exam. The purpose of today is to give you an absolute watertight, comprehensive overview of this assessment, tell you exactly what you're expected to know for the exam, the actual exam day itself, how to best prepare yourself, and then at the end, I'll answer any questions that you've got. If you can, just leave your questions until the end, and I'll happily answer as many as I can for you. If we can just try and keep the questions relevant to this particular exam rather than the foundation program application, that will be greatly appreciated. Okay, so thank you all for being here, and thank you for giving me your attention. I will now begin. So by now, or very, very soon, you will have received an email worded something like this. So we've reviewed the information you've provided and are pleased to inform you that you are eligible to apply for the foundation program commencing in August 2026. However, your eligibility application is subject to you passing the clinical skills assessment. Year in, year out, the students receive this same email, and all it says is essentially for you to be able to start your FY1 next August, one of your requirements, of course, you may have more, but one of the requirements is the successful overcoming of the clinical skills assessment exam. It is a bit of a scary exam, only in that it happens once a year. So there's only one time that you get to sit this exam. I think that's what makes people a little bit nervous about this exam. But hopefully by the end of this, certainly, by the end of this 2-hour webinar, you will be able to get all the information you require to be able to at least know what the exam entails. So the level of the exam. Obviously, none of you have worked as doctors before. You've all, I would say recently or a little bit later have graduated from medical school. Some people have been out of medical school for many years now. This is designed to test, are you competent enough to start work as a foundation year 1 doctor? It doesn't mean that you've worked as a doctor before, but do you have the skills and the knowledge and the level of professionalism required to be able to start day 1 as a foundation year 1 doctor in the NHS? Okay, so that's the level it's set at. It's actually set at the level of someone who's just recently qualified from, for example, a 5th year medical student who's literally walked out of medical school and the next day is starting FY1. That's the level this exam is set at. So from that perspective, it makes it a little bit of an easier exam in terms of the curriculum. Things that are covered in the exam is easier than other OSCEs. However, it still may seem a little bit tricky for some of you who have never probably been around the NHS environment before, or B, obviously never had enough clinical experience, for some of the skills that are tested. But that's the level it's set at, the level of someone who is about to start F1, not someone who has finished F1. This chap, we'll talk a little bit more about him. He is a very, very important man, and I will explain who this elderly figure is in a moment. So the actual exam itself is an assessment of not only clinical skills, but a wide range of core clinical competencies. And there are four. The first one will be history taking, and we'll talk about this in much, much more detail as the webinar progresses. The second is communication skills or counseling skills. The fourth is your practical procedures. The third, I beg your pardon, is practical procedures, and the fourth is clinical examinations. Now, there are obviously subsets within these, but those are the four broad things that are tested as part of the core clinical competencies for the NCA exam. History taking, communication, practical procedures, and clinical examinations. And it is an assessment for those that graduated from medical school more than 2 years prior to the initiation of their foundation year program, which will be August 2026. So anyone who has graduated, irrespective of nationality, country of birth, country of degree, you will all have to sit, obviously that's why you're here, the NCA exam, if you graduated before the 5th of August 2024. And the format, which I will talk to you in more detail about, is an OSCE. Okay, and that's what brings me to this gentleman here. This man is Professor Ronald Harden, and you can thank him or you can blame him for the reason as to why you're sitting this exam. So this is the chap. He graduated, or he worked in the University of Dundee in Scotland, and him and his colleagues, I believe it was in the early 1970s, they came up, they changed the whole examination system, particularly for UK, and they were the ones, and particularly this man, Ronald Harden, who was a professor in endocrinology and medical education. He was the one who developed the OSCE exams. Now, obviously, NCA is not the only OSCE in the world. There are many, many other ones, including PLAB2, etc. But obviously, the NCA itself is an OSCE. And what that means and how they operate, I will talk to you when I talk about the actual exam format itself. So the NCA exam is an OSCE, an objective structured clinical examination, and it very authentically represents what you will see on a day-to-day basis when you actually start working as FY1 doctors. And this is just to highlight that every single person, irrespective of citizenship, nationality, country of medical school, or GMC registration status, has to sit the clinical assessment exam if you graduated from a medical school before the 5th of August 2024, which I'm assuming is all of you. Okay. Why it's important? That, well, first of all, it determines your suitability to start the foundation program. It is an absolute requirement. If you fail the NCA exam, you are automatically withdrawn from the UK foundation program application. And although I don't want to sit here talking about failure today, it does happen. Okay, the pass rate is not 100%. And if you are in that unfortunate category of failures, or you've been unsuccessful in the exam, then that pushes your life back quite significantly, because the application for the UK Foundation Programme is only once a year, typically during this period, July, August, and September. And the exam is held in November. So if you are unsuccessful in November, you have to wait till the next year to apply, which is July 2026. And then you can only start your FY1 in August 2027. So you see, that for me is the most important thing about this exam, is that it's an absolute requirement, and failure leads to pushing your life back quite considerably. Therefore, even if you've done other OSCEs, particularly PLAB2 is the big one for GMC registration status, you have to take this exam very seriously, and the way you prepare yourself for this exam has got to be very, very focused. You cannot use, although people do, they use a lot of the information that they've acquired during the PLAB2 preparation for this exam, but it requires very meticulous preparation, because what it assesses is very different to PLAB2, and the manner in which it assesses you is different to PLAB2 as well. So you have to give it the respect that it requires. Okay, and it's only valid for 2 years, the clinical assessment. So you should have started your foundation program within 2 years of passing your clinical assessment exam. Now, the dates. You will receive an email saying that you are required and you're required to take the clinical assessment exam, and you're required to make payment as soon as that link is sent to you by the 18th of September. Failure to make the payment by that deadline, and this is the date for this year, 18th of September by 12 o'clock. Failure to make the payment by that date will again, unfortunately, withdraw you from the foundation program application. So make sure as soon as you get the link, soon you get the confirmation, which should be coming up soon if you haven't already received it, please make sure you make the payment as soon as possible. And the payment is £850. It's non-refundable, so make sure that you are truly ready to sit the exam, okay? Because it's an expensive exam, but an important one. The dates have never changed. They have always been in the first week of November, okay? They are run over 4 days. So you see here, the dates are the 3rd to the 6th of November, okay? And obviously you're only going to sit the exam on one particular date in one particular cycle. So within each day, you have cycles, so a morning and an afternoon. So you'll have 8 cycles in total, 2 on the 3rd, 4th, 5th, and the 6th. And which venue you'll be at, which cycle you'll be at, and which date you'll be taking the exam, you will be emailed this information by the 6th of October. Okay? And that is, again, the timeline as specified by the UK Foundation Programme Office. I don't see this time changing. Okay? So by the 6th of October, you'll know exactly when your date is going to be. Now, there are some people, and this has happened more frequently in the last few years, have also had to sit PLAB 1 in the early November PLAB 1 date. And there is an overlap between PLAB 1 and the National Clinical Assessment Exam. However, please make sure that you've emailed the UK Foundation Programme Office if you have a PLAB 1 exam booked for this particular period to ensure that the dates do not clash, and they will ensure that your PLAB 1 will go ahead and that you'll sit the clinical assessment on a date other than the one that obviously you're sitting PLAB 1 on. Okay, so please make sure that you let them know that, and they'll obviously already have confirmation from you sent to them about your PLAB 1 booking. Okay. Importantly, the OSCE is different on every day. Now, obviously, in the past, there have been some very similarities and repetitions between cycles. However, they will be different, but they are very carefully designed to ensure equivalent difficulty. That means that the 3rd and the 6th are not going to be any more difficult than one or the other. Okay, and they test almost the same things, and we'll talk about that in much more detail when I come on to what is tested in the exam. So the dates, these are fixed, these will not change. There are 2 centres. There used to be 1. When I sat the exam in 2014, there was only Wythenshawe Hospital. Both of these are part of South Manchester NHS Foundation Trust, but there is a newer one in the last few years, the Oxford Road campus. I've been asked even last year, is any one centre more difficult than the other? And the answer is absolutely not. They test the same stations, if you like. The same clinical competencies are tested in both of the venues. So no venue is any more difficult than the other. Okay, and they are part, again, of Manchester University Hospital. The reason why the UK Foundation Programme Office choose Manchester University Hospital is because they are pioneers of OSCE and medical education. They have taken the OSCE format and made it sort of a standard now. That they are the gold standard of running OSCEs, the Manchester Hospital NHS Foundation Trust. That's why they use these venues, and they have a highly pooled of very experienced simulated actors that they use for your exam, and we'll talk about those a little bit later. So these are the 2 centres, and obviously you'll only be sitting at one of these. The actual exam day. So on the 6th of October, you'll be emailed what day that you'll be sitting the exam. Okay, you're allocated a day and a time to report for your assessment. Please make sure that you are absolutely on time. Do not turn up late to this exam. Okay, they will refuse your entry if you're past a certain time. So please make sure that you make adequate travel arrangements to whichever respective campus you're sitting the exam at, that you either stay there the night before, which is what I recommend, or you travel with ample amount of time in advance. Okay. Now, the things that you need, obviously, you need a identification and you need your email that shows your foundation program, your FPAS reference number on there, okay? Passport, driving license, whatever government identity document that you have, please make sure that you take these things in. You'll receive an email detailing exactly what you require on the exam day, but obviously government ID, if you do not take this in, you will not be allowed to sit the exam. So that's very important. Okay. You have to bring your own pen. You must bring a stethoscope with you. Please make sure you take your own stethoscope, but every other clinical equipment that is required is provided in the exam for you. So if you need a tendon hammer, a tuning fork, whatever it may be, all of these things will be provided for you in the actual station itself. So you don't need to take anything else other than your identification, the email showing your booking with your FPAS reference number, a pen and a stethoscope. Everything else will be locked away. Your phones, any electronic devices, any textbooks, notes, materials that you bring in, all of that will be locked away in a locker that's dedicated for the candidates. And then obviously you'll receive that at the end. And then between cycle 1 and cycle 2, because there's a little bit of an overlap between the two, they'll make sure that everyone is kept very segregated so that there can't be any discussion between the candidates of cycle 1 and obviously the candidates of the afternoon or cycle 2. The assessment structure. I've already mentioned that it's delivered by Manchester University NHS Foundation Trust. Historically, when I sat the exam and up until COVID 2021, there were 16 stations in your exam. Now there are only 12, and over the last 4 years, there have only been 12 stations, okay? Also known as clinical competence assessments. We're going to refer to them as stations because that's how they are in your exam. Okay? So there's only 12, and there will only be 12 in this upcoming exam. Each stage, now this is a little bit of a longer exam than your other traditional exams in terms of station length. So you have 10 minutes, but that 10 minutes includes 1 minute preparation time. So each task, each station is only 9 minutes long. Okay, so that 10 minutes is broken down 1 minute reading time, where you have a task outside the door or outside the cubicle. Then you'll have a warning bell, or the invigilators will say, please enter. You enter your station, you greet the examiner, you read the task again if you haven't quite understood or you haven't had time to read the whole task, and then you perform whatever has been asked of you in the station itself with the simulated actor, with the examiner, or with a mannequin. Okay, so 10 minutes in total for 12 separate stations. 1 minute reading time, 9 minutes of performance. The exam roughly lasts around 4 hours, and obviously you've got 2 sessions, so it will take up the whole day. Cycle 1 will last anywhere between 8 and 1, and then cycle 2 from, for example, 12:30 up until 5 o'clock. So you expect it to be there for around 5 hours in the actual building itself, but the exam will last around 4 hours. The instructions are outside each task, but if you need to read them again, you're very welcome to do so. You're not going to be marked down for reading the instructions again. And in fact, you are encouraged to read the instructions again to ensure that you have fully understood everything that has been asked of you within the instructions before you approach the simulated patient. Okay? And I'll give you an example of what the instructions look like as you enter the cubicle. This is the layout of the exam room. And I'm going to try and describe it to you as if you were actually there. So Wythenshawe, I did it in Wythenshawe Hospital. And the exam was divided into two places, okay? So if you imagine there's a corridor here, and there was one clinical area and a second clinical area. Okay, and all you had to do was, once you did your 6 stations, the invigilator would take these candidates over to this area, and then they will go for the remaining 6 stations. So let's say you start outside station number 1, and the task is a clinical examination station. You will then have your 10 minutes, and you move on. Once the 10 minutes elapsed, station 2, and so on and so forth. It's very obvious where you need to go. If you don't know where to go, there will be plenty of people around to move you to the next station. Okay, from station 1 to station 6. Once you've done your 6 stations, you will then have a rest. Okay, and then I think the rest is about 15 minutes. And then once that 15 minutes rest has taken has elapsed, you will then move on to the second area, which will have your remaining 6 stations. And generally, the exam is broken down into clinical examinations and practical skills, and history and counselling. Now, obviously, there are many different things that are tested in this exam. So it's not broken down exactly like that, because you've got 12 different areas of clinical competence that are tested. But generally speaking, all the practical examination-based scenarios are in one section, and all the talking, history, counselling, handover, prescribing are in another section. Okay? And what I will tell you is, particularly Wythenshawe and Oxford Road campus was very similar, having got feedback from previous candidates, is that it's not like PLAB 2, where you move from room to room to room. It's not a room, it's a cubicle. So you imagine you're in hospital and you have patient number 1, you have a bay of patients. So you have 6 patients with a curtain that is pulled around you. Now, there is no curtain that's pulled around you, but you have dividers that divide you from one station to another, which makes it a little bit off-putting because you can hear the next candidate. Now, I can't change that for you, obviously. You have to try and block out that noise as best you can and really zone in and focus on what's being asked of you. But you can hear the next candidate, unfortunately. And if they're really loud and annoying, you just have to try and block that out. It's a little bit different to how the GMC have structured their OSCE examination, where you actually enter a room, you close the door behind you, and you are in a noise-free environment to perform the task that's been asked of you. This exam is different to that. Although you have stations, they are only they're only divided by very small dividers or curtain rails. Okay, so it's very easy to get distracted by the noise. So you have to really focus in the exam so as to not let that noise distract you from performing your task. Okay, so just remember that when you go in the exam, that is how it will be. Okay, that's not going to change. 12 stations, 6 and 6, segregated by a very small 15-minute break. And then, for example, if you're in 1 to 6, you will then move over to 7 to 12. Okay, so the format is not going to change. The structure is not going to change. The number of stations, the timing, the exam length will all remain the same. A sample station. So when you park yourself outside station number 1, and you'll have a sticker, and it will tell you obviously your name will be written there, your FPAS number will be written there, and your station number will be written there. So you park yourself outside that particular station. Let's say you're outside station number 1. It will say instructions to candidate. Okay, so these are posted outside the station. You've got a minute to read them, and you can also refer to them again. Line number 1 is always who you are and what department you work in, and you're always going to be an FY1. So you're an FY1 working in psychiatry. Line number 2 is your patient. So here we have Mr. George Thompson. He's a 35-year-old patient who's been brought in by the police for strange behavior and hearing noises. Then you may get a small paragraph describing in a little bit more detail as to what, a little bit more background, if it's a history, for example, or if it's a counselling station, generally the tasks are quite small, but some stations, the tasks are much longer. For example, the handover stations or the prescribing stations, you may get more information in the task, which you'll need to use when you go inside. If the task is really long, try your best to read as much as you can. If you haven't finished it, go inside and read it again, because the very last line will be your task. Please take a psychiatric history and perform a mental state exam and explain to him, the patient, the further management. So this is a sample station of what you're expected. Psychiatry is a very popular station in your exam. It comes every single year, and this is the structure in which the questions are asked of you. Now, obviously, the reason for today is not to talk about everything that's going to come up in the exam. That's not possible in 2 hours. But I'm just giving you an overview of what to expect in the exam and what way is the exam tested. The content. This isn't going to change either. The content has been the same since I took the exam in 2014, and it will still be the same in 2025. Okay? The content, and I'm going to break these down and talk to you about them in more detail. There are these areas that almost every exam focuses on. And I'll say almost every exam because not every exam picks a station from each of these. Okay, they may skip one of them. For example, discharge planning might not come in your exam because remember, there are only 12 stations. And look how many competencies there are. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. There are 11 clinical areas of competency that are tested. They cannot test you on all of them, but there will be a clever mix of most of these in all of your exams. Okay, these 11 clinical areas of competency, and I'll talk about each one of them individually. The first one, which is guaranteed. Now I'm going to tell you which ones are absolutely guaranteed in your exam, the ones that are less likely. Focus history taking is 100% coming in your exam. History taking for the National Clinical Assessment is a little bit different to PLAB 2. Okay, and I'm going to compare it to PLAB 2 because it is an exam that some of you have to sit. Okay, not all of you, but some of you, if not most of you, have to sit for GMC registration. In PLAB 2, you have what are known as combined stations, where you have a task, you take a history, you physically examine the patient, you discuss the diagnosis with the patient, and then you discuss the management with the patient or with the examiner. In the NCA exam, it is purely history taking. Okay? So your task is, for example, a patient comes in with difficulty in passing urine, or difficulty in swallowing, or shortness of breath, or cough, or diarrhea, or whatever it may be. Your task is to take a history. Not to discuss it with the patient, but take the history and come up with a diagnosis or a differential diagnosis, and then at the end, discuss investigations, management with the examiner. Every single station, all 12, you will be speaking with the examiner, all of them. You will have questions from the examiner at the end. That is guaranteed. Even if you've done absolutely amazingly in a practical procedure, you'll have questions. They will have set questions that they want to ask you for every single station. That includes history. So once you've taken your history, once you've used a structured approach to try and get out all the information from the patient to come up with a diagnosis or a differential diagnosis, the examiner will then ask you, so tell me what your thoughts are. Tell me what you'll do next in terms of investigation, and tell me how you'd initially manage this patient. So these are the questions, and what are the complications of this condition, etc. So there will be set time allocated in every station for the examiner to ask you questions. Okay, that is guaranteed. So remember that. Focus history taking essentially covers medical and surgical clinical complaints. It does not, in your exam, cover obs and gynae, and it does not cover pediatrics. It has never covered pediatrics, and it never will. It has never covered obs and gynae, and again, it never will. Because you don't do obs and gynae as an F1. You don't do pediatrics as an F1. Therefore, they are not part of your exam. Okay? And you can hold me accountable if you want. I say the same thing every single year, yeah, to all the candidates that come onto the course or who to listen to me. Don't study obs and gynae. Don't study pediatrics. They're not going to come up. Okay? It will be common medical cough, shortness of breath, diarrhea, constipation, chest pain, headaches, abdominal pain, back pain, joint pains. Those kind of presentations. Very, very common. And they repeat year in, year out. It's the same clinical complaints that come in and year out. Why? Because these are the common clinical complaints that you're expected to be able to take a history from to come up with a provisional diagnosis, initiate investigations that might lead you to a diagnosis or exclude other conditions that you need to exclude, and then at least an initial treatment plan should be made by you as an FY1. Okay? So no obs and gynae, no peds, but certainly medical and surgical, for example, abdominal pain, very, very common stations that will come up in your exam. Okay? History taking is always with a simulated actor. You will never get a real patient in history taking. Never. They are all highly experienced actors for history taking. If they're in pain, they will show you they're in pain. If they want to cry, they will cry. They are highly experienced, trained. They've gone to acting school. They know how to act. You don't need to. They will do whatever has been scripted for them. They will behave in that way. If they show immense pain, that's not because they really have pain. I was asked by a candidate the year before last. They had the abdominal pain station that came up, which comes up every year for almost everyone, abdominal pain. And the person was in such great pain, they thought that the patient was a real patient because the acting was of that caliber. Okay, so just be mindful. History taking will always be a simulated actor. They're not going to bring anyone in with acute pain. Okay. History taking in difficult circumstances for you, for your exam, is mental health, is psychiatry. Yes, if you look at the UK Foundation Programme Office Handbook, they say under this category, you have patients with language problems, speech problems, or hearing impairment. That's not going to come up in your exam. Okay? The history taking in difficult circumstances is mental health, is psychiatry, which again is almost, I say, 100%. Almost 100%. You will get one clinical complaint from focus history that is guaranteed. Psychiatry is very, very, very high yield. And again, psychiatry clinical complaints are, although in reality there are a large number of different clinical complaints, for the NCA, they are very finite in number. For example, psychosis, depression, mania. There are only a small number, or anorexia nervosa, eating disorders, only a small number of psychiatry stations that come up. Okay? But you need to know how to take a good psychiatric mental health history. You need to understand the intricacies of a mental state examination and how you give that information back to the examiner, how you summarize it back to the examiner, and then obviously know the not everything in terms of management, but at least, again, the basic investigations and basic treatment strategies of common mental health disorders. For example, schizophrenia and depression and bipolar disorder. So again, there are not many, but there are some important ones that you need to know. So focus history, guaranteed. Psychiatry, almost guaranteed in your exam. Examination of patient with stable chronic disease is a must. You cannot pass this exam. You cannot pass the NCA exam without knowing how to examine a patient with chronic stable disease. Okay, what does that mean? That is the presentation that is not acute. Okay, not the A, B, C, D, E assessment of someone who is acutely unwell, but someone who is stable. Okay, this is your traditional clinical examination, OSCE. For example, respiratory exam, cardiovascular exam, gastrointestinal examination, rectal, thyroid, peripheral vascular disease, all the different types of neurological examinations, cranial nerve, cerebellum, upper limb motor, lower limb motor. There are so many. And this section, for me, makes NCA a tricky exam. Because if I compare it to PLAB 2 and I compare it to other OSCEs, I teach many, many OSCEs. Okay, not just PLAB 2 and NCA, I teach many different OSCEs. If I compare NCA to the other OSCEs, actually the list of stable chronic examinations is a lot more. There are many of them. Okay, at least 30 examinations are required for you to know, and they are all common. Orthopedic exams, hip, elbow, shoulder, knee, these come year in, year out. Very, very common. Fundoscopy, otoscopy. So yeah, examination of patients with stable chronic disease is a guaranteed. You may get one, you may even get two of these in your exam. Okay, but this section often is the pass or fail because there are more of these as compared to the other ones. So you need to know the steps of the clinical examination really, really well for your exam. And again, because there are so many that are tested, you need to spend a little bit longer on this section than you will with the other ones. Okay, very important section. Another thing to mention is historically, there have been real patients that have been brought in for this particular section. Even in the most recent exams, there have been real patients from the hospital with stable findings. They're not acutely unwell in any way. They bring them in. They have various findings. For example, if you're doing a cardiovascular exam, they may have a murmur, they may have a pacemaker, they may have scars. For example, a median stenotomy scar for previous bypass surgery, etc., etc. Respiratory, they might give you a COPD patient that is stable. They may give you pulmonary fibrosis. I remember for my exam, I had a musculoskeletal exam, which was a lower limb, I beg your pardon, neurological exam of the lower limbs. And it was a stroke patient. It was a real patient, an elderly man. So for this section, it is important to know that you may very well get a real patient in your exam. Okay? They may be simulated, they may be real. And obviously during the course itself, I will tell you exactly which stations have real patients and which stations have simulated actors. Okay, but just be mindful that you will have a mixture of real and simulated, and the list of examinations is quite large. Prescribing guaranteed. 100% safe prescribing is going to come up in your exam. Traditionally, again, pre-COVID, after COVID, a lot of things changed. Pre-COVID, the prescribing station was actually quite a nice station. I remember walked in the station and I had a patient on oxygen, obviously a simulated patient, but he was sitting on oxygen. And from him, my task was to take a medication history and then sit down opposite the examiner, and I had his prescription in front of me, and I had to make alterations on that prescription to make it a safe prescription for that patient. So for example, this man had a fever, cough, shortness of breath. So it was a suspected pneumonia case. I had to take all his medications, I had to put them on the inpatient chart, then I had to prescribe him the most appropriate antibiotic, and then I had to look at the chart and see if it was a safe prescription. Were there any drug interactions between his drugs and the drug that I am proposing for him to be on? And are there any contraindications for medications that he came in with because of the clinical state that he's now in? So, for example, he had a penicillin allergy, and I had to prescribe him clarithromycin, but he was on a statin. So I had to remember that there was an interaction between the statin and the clarithromycin, and that I had to withhold the statin for at least a period of 7 to 14 days on the chart, and then prescribe him the clarithromycin. Okay, and there were some other drugs, for example, I think it was on diuretics and an ACE inhibitor that I had to stop because his blood pressure was low. So these prescribing cases, you have a few things to do within that station. You may have to take a whole medication history, which includes all the drugs that the patient takes, their allergy status, etc. You have to then go and sit down and prescribe on the inpatient chart their drugs, taking into consideration any contraindications to their current clinical state, and then prescribe drugs that is necessary for them for the condition that they've come into hospital for. For example, an infection, pneumonia, UTI, cellulitis, asthma attack, COPD. And again, there are common themes that come in prescribing year in, year out. You will have a copy of the BNF. Nowadays, you'll have the electronic form of the BNF, which is very, very easy to use. During the course, I will show you exactly how to use the BNF easily to save yourself time, so you don't have to fiddle around on the iPad, wasting time trying to figure out what part of the BNF to use. I will show you within 1 or 2 clicks how to find the answer for almost every prescribing scenario. Okay. The reason why prescribing is definitely tested in your exam is because it is one of the requirements for you to progress from a foundation year 1 doctor to a fully registered foundation year 2 doctor. Actually, you have a separate exam for this, the prescribing safety assessment, the PSA exam, which is a mandatory exam for all FY1 doctors to transition from provisional to fully to full GMC registration, but they do test it in your exam. It's one of the things that you'll be doing every day, irrespective of the specialty that you will be in. Whether you're in psychiatry, A&E, any medical department, you will be prescribing every day from day 1. Okay, that's why they test it. Okay? And that's why they test it even more as a separate exam, the prescribing safety assessment. Now, in the newer format of the exam, which I find, well, a little bit more relevant for you, is you want to have a patient. You'll be sitting down opposite the examiner with the BNF available to you in hard copy and also in electronic form. And you'll have a prescription in front of you. You'll have a clinical case. So for example, you have a 35-year-old patient who's come in with an acute exacerbation of asthma. Their treatment has already, their regular drugs are already prescribed on the chart. Please prescribe any acute medications that are necessary and make any amendments to the inpatient chart. So for example, this asthmatic on their inpatient chart was on a beta blocker, was on ibuprofen for pain. And you have to understand that these 2 medications, both beta blockers and non-steroidal anti-inflammatory drugs, are contraindicated in asthmatics and have likely triggered this acute asthmatic event. So you have to stop those drugs. So these are contraindications, again, according to the initial clinical complaint. Then you have to prescribe the patient drugs that are necessary to alleviate the acute asthma. So for example, prednisolone, beta-2 agonists, for example, salbutamol, and you have to know where to prescribe them on the chart and how to prescribe them and how you can use the BNF effectively to be able to find that information and then transfer it onto the treatment chart. So this section, I think a lot of people do find difficult because, again, you've never prescribed before. And the UK Foundation Programme Office, on their registered area, which you should get links to from the UK FPO, they'll send you links. They have a sample treatment chart on there that you can practice with up until your exam. Okay? There's one for fluids and there's one for inpatient drugs and antibiotics. Have a look at that. It's a very simple, very, very simple. It's actually a lot less complicated than actual real inpatient charts, but it's very, very straightforward. And again, during the course, I will cover prescribing in its absolute entirety for you for your exam. By the end of your FY1, when you walk into FY2, this is a skill that you have to have grasped. Okay, you have to have grasped this skill before you transition to an FY2. The recognition and management of acute illness. This is 100% in your exam. You only one station, but 100% is coming in. This is your traditional airway, breathing, circulation, disability exposure approach to managing acutely unwell medical and surgical patients, the ABCDE approach. You will have a task. For example, a nurse is concerned about a patient on a ward who has suddenly become unwell. Please assess the patient. During that assessment, you do your ABCDE. You institute management wherever necessary during that A to E, and then you turn to the examiner and you tell them what you think is the reason behind the acute deterioration. And then you, any further management, for example, if it's an acute asthma attack, any further management will need to be discussed with the examiner. Any investigations, any ongoing management needs to be discussed with the examiner. Okay. So ABCD is guaranteed. And there are a number of stations in your exam that come for ABCD assessments. I'm not going to list all of them now, but common ones are things like sepsis. You have acute asthma, acute COPD, acute coronary syndrome, heart failure patients, etc. Okay, you have to be able to recognize the illness, and you have to be able to manage the illness as well. It says here psychiatric emergencies. They're not going to come up in your exam. These are usually medical or surgical emergencies. So please be ready for this for your exam. ABCDE approach. Surgical and perioperative care. Not guaranteed, but very likely. Okay, not guaranteed, but very, very likely to come up. This is talking about a particular common procedure to a patient. These are counseling stations. So you're counseling them about everyday common operations that take place. For example, herniorrhaphy or hemiarthroplasties, or investigations, for example, OGDs, colonoscopies, appendicectomies, cholecystectomies. Again, the list is finite. It's not every single operation. No, there's a common list of common operations and investigations that you need to know about. And again, this is a relatively straightforward station, providing that you know how to communicate in layman's terms, but effectively enough that you give all the information out to the patient and they understand all the information that's given to you about that particular surgical operation or investigation, then you would have passed the station. Okay? So surgical and perioperative care includes not preoperative assessment, not postoperative care, but for your exam, it is about surgical operations and the counseling of these operations to a patient. Okay, again, very common for your exam. They are testing both communication and management. Discharge planning, less common, very, very less common, but does show up every now and again. Discharge planning is ensuring that patients go home safely. For example, the classic one for the NCA is the elderly patient who's had a fall. They've had a fall, they've broken their hip, and now the time has come for them to go back home. You have to talk about all the social aspects of their care that need to be addressed. So, for example, the role of other allied healthcare professionals, physiotherapists, occupational therapists, and social workers. You have to know the roles of these professionals in the discharge planning process of patients. So that's the classic one. The patient who has fallen over, the elderly patient, and you want to send them home, are you able to talk about the other professionals that will look after their care once they're medically optimized for discharge, when they go back home, that it's safe for them to transition from hospital back into their home environment? The other discharge planning stations that can come up are your lifestyle changes. So the two big ones for your exam are the post MI and post stroke or TIA counselling. So patients had an acute coronary syndrome or had a stroke, they're going back home. Talk to them about lifestyle changes that they can make in order to prevent these events from happening again in the future, or minimize the risk of these events from happening again in the future. Okay? These are all part of discharge planning. And the final one is talking about medications on discharge. So, for example, an asthmatic patient who has been treated for acute asthma is now going home. Talk to him about his inhalers. Talk to him about the peak flow meter. Okay. So discharge planning can come in a variety of different ways. The first one is the elderly patient and talking about allied healthcare professionals that are important to help them transition safely back home after their acute medical need was overcome. The second is talking about lifestyle changes that patients can make at home in order to prevent them coming back into hospital for the primary reason, for example, strokes and cerebrovascular events. And the third is medication explanations, for example, post MI medication explanation or post asthmatic patients. Not a very common section, but there are certainly things in this that you do need to know for your exam. And it's an easy section for the exam. Teamwork or the handover stations, again, guaranteed. This is 100%. One of the critical skills required for an FY1 doctor to work well enough to be able to, excel in their role and work in their role effectively is to work effectively as part of a team. You will never, ever succeed if you think you can work alone. You will never succeed. Okay? You may pass, you may go from F1 to F2, but failing to recognize that patient care is always a team effort, you will never succeed. And that's why they brought this task in. Now, the teamwork or handover station is very predictable for the NCA. I'll tell you how it comes. You will have in your station 2 or 3 patients that are described on the task for you. 2 or 3 patients. Okay. Now, for each one of these patients, you have to your consultant, who is the examiner, you have to hand these patients over to the examiner and tell them what investigations and what management that you would do for these patients. So, for example, patient number 1 would be a patient with DKA, for example, diabetic ketoacidosis. Using the standard S-bar method of communication, situation, background, assessment, recommendations, you have to give the information to the consultant. You have to tell them what investigations that you're proposed to do and what treatment that you would initiate in that patient. For those that are unfamiliar with the term clerking, clerking of a patient is seeing the patient right at the beginning of their care. Okay. So, for example, a patient comes to the emergency department, A&E. They've been seen by an emergency doctor and they have decided that the patient needs admission. Okay, they can't go home for whatever reason it may be. Let's say it's chest pain. And you have to clerk that patient in. That means you take a history, you examine them, and once you've done these things, you will then order preliminary investigations to come up with a diagnosis or exclude other differentials, and then some form of management plan. This is the clerking process of a patient. Once you've clerked a patient, because you're only an F1, a senior member of staff has to ensure that they have what we call post taken your patient. That means they've seen your patient, they've reviewed your patient, and they have then put some changes into your management plan or said, no, everything's absolutely fine. So this station of teamwork is like doing a post-take ward round with a consultant. History's been taken, it's in the task. Examinations been done, it's in the task. Investigations, again, have been done, they're in the task. It's about giving that information to the consultant, working out what treatment that you would have done. So that treatment is not in the task. You have to figure out that treatment from your head, tell the examiner, tell the consultant that this is what I have done. Now, do you recommend me doing anything else? Okay. And then you have 2 or 3 patients that you have to work through with the consultant. That's the newer way of teamwork. The older way, which may still show up in your exam, is handing over or receiving handover from an outgoing F1. I had this. I remember it. I remember it even 11 years later. I still remember the task. There was an FY1 doctor, and he was in a rush to leave. He had a party. He had a family function he wanted to attend. And he stood up. It was a very small cubicle in the corner of the room. Very small cubicle. And he stood up and he said, oh, thank God you're here. You know, and let me quickly hand over these 2 patients for you. And I've got to leave. I've got a party to go to. Okay. And I was thinking, I had a piece of paper and a pen. I said, okay, but let's just, so we sat down and he handed over 2 patients to me. What I had to do then was which I didn't in my task, but I had to get out more information from him. Because he was in a rush, he wasn't giving me all the information that I needed for a successful handover. So there were parts of the S bar that were missing. But me, because I didn't know what was going on, because he was pushing me because I was in a rush, I was just writing down all the information that the FY1 was giving me. And then I said, okay, you go. So now the examiner turned around and said to me, okay, do you have enough information to be able to prioritize patient 1 over patient 2? And I looked at the information, and obviously I didn't have enough information. Okay, there was not enough information because I didn't ask enough of a history. I didn't take enough of a history from the FY1 doctor or from, for patient 1 or patient 2. So the examiner said, okay, so which one is the more serious, 1 or 2? So then what he said was, sit back down, ask the FY1 questions now that you need information for. So then I went back and I went, okay, so tell me a little bit more about their medical background. What medications are they taking? What investigations have they had done? What do you actually want me to do for the patient? So there's a structured approach that you have to take when handing over or receiving handover from a patient, which at the time I didn't know. Obviously now is different. And then with all the information from patient 1 and patient 2, I sit with the examiner and I have to answer questions about which one is the greater priority, which one is the more sick patient that I have to deal with imminently. Okay. And I remember the 2 patients. One was a query subarachnoid hemorrhage, and the second one was a stroke patient. Now, the stroke patient had all the investigations done, all the management started. I had just had some routine bloods to look out for. Whereas the subarachnoid hemorrhage still had the CT scan of his head pending. So that's why the examiner asked me which one for you is the greater clinical priority. And I had to work that out. It is obvious in your exam which one is the greater clinical priority and why. Okay. So that's the teamwork or handover stations. It's more likely in your exam that you get the first one that we discussed, whereas you have patients written on a paper. You have to come up with a diagnosis based on the information you read. You have to come up with investigations. You have to come up with management, and then you have to explain all of that to a senior member of staff and answer questions from them. So this is a guaranteed station in your exam. Challenging communication, again, guaranteed. Yeah, 1 station is guaranteed challenging communication. These are angry patients, angry relatives, These are DNAR discussions. Okay. These are breaking bad news. These are going to come up in your exam. Okay. Angry patients and breaking bad news come every single exam. So you have to be familiar with the exact approach of breaking bad news and how to deal with angry patients and about the complaints process and how to manage those patients and how to diffuse and de-escalate situations. Okay. Challenging communication. Please make sure that you are familiar with the Bailey-Spikes method. The Spikes method is the most accepted method of breaking bad news to patients. This is almost guaranteed for all of you to come up one breaking bad news scenario. Okay. Ethical and legal issues is a separate station, but actually very similar to challenging communication. But these test ethical issues. For example, capacity assessment is the most common one that comes in almost every exam. Are you able to assess the mental capacity of a patient? Are you able to talk about resuscitation with patients? There are not many legal issues in your exam that you need to be aware of, but Mental Capacity Act is something that you need to be very familiar with. You don't need to go and read the whole good medical practice. You're going to be wasting your time doing that. Okay? There are only a handful of ethical and legal issues for your exam that you need to be familiar with. And capacity assessment is the most common theme that comes year in, year out for your exam, and very likely to come up again this year. This is perhaps the least common station, the health promotion and patient education. The task says it all, okay? Alcohol, smoking, drugs, obesity. Okay, these four things: alcohol, smoking, drugs, obesity. Can you take a history, and can you counsel the patient, and can you promote good health using the evidence-based approach to managing these various health issues? Okay, alcohol, smoking, obesity, and drugs. They're not common scenarios anymore, but they used to come in almost every exam in the 16 station NCA. Now, because there's only 12, there's much more important things for you to focus on. Okay, so this is an easy section. Time should not be spent too much on this section, but however, know that it is still a part of the curriculum that you need to be familiar with. And finally, practical procedures, which is a guaranteed, one or two. This is equally as important as examination of stable chronic patients. There's a limited number of stations here. Okay, there are limited numbers of stations. The list is not long. Venipuncture, cannulation, IV injections, IV fluid administration, arterial blood gas, male catheterization, testicular examinations. For some reason, they put in practical procedures, I believe because it's done on a mannequin. Rectal exams, again, it's an examination, but done on a mannequin. Breast exams, again, it's a clinical exam, but done on mannequins. ECG, performing an ECG and interpreting an ECG is a practical procedure. Intramuscular injections, subcutaneous injections. Okay? There's about 15, 16 practical procedures that you need to be familiar with for your exam. So this is an easier section, providing that you practice it enough. And there are very common ones that come in almost every exam. ABG, arterial blood gas, is every single exam I have seen has arterial blood gas in, or if not 95% of them have arterial blood gas done on a mannequin. So there are very common ones within this list for practical procedures. Blood culture, very, very common recently, has come up in almost every exam in the last couple of years. So you need to be familiar with how to take blood cultures as well. And obviously during the course, we will look at all of these in great detail, and I'll perform them for you, and you can practice them unto your heart's content. How to prepare. I've been asked before, is a PLAB 2 course enough for NCA? My answer has always been the same. It may be. Okay. PLAB 2 is set at the level of FY2. Okay, so it's set at a different level. But the preparation required for PLAB 2 and NCA are a little bit different because they test OSCEs in a slightly different way. Now, if you've done a PLAB 2 course, it is likely that you will pass the NCA. Okay, but you have to know that they are two different exams. So your focus, and I've never changed what I've said about this, your focus should be on the NCA alone. Okay. Now I've been teaching this again since 2015. So this is the 10th year now I've been teaching this for. I know the ins and outs of this exam like no other because of the length of time I've been doing it for, and because I've done it myself. And obviously, because I've been teaching F1s for the past 8 years. I've been, ward-based teaching for F1s for a long, long time now. So practice amongst people that are sitting the exam is one of your most effective methods of preparation. Okay? Practicing with each other. You cannot downplay the importance of practice. You have to role play, you have to practice until it is perfect. You have one chance at this exam. You don't have two, you have one chance. Okay. If you want to apply the second year and wait another year or two, that's up to you. For me, for any exam I sit, I have one opportunity. I don't look at a second. So you have to practice as much as you can. The problem comes, what do you practice? How much do you practice? Do you use PLAB 2 materials? What is it that you practice? This is where, obviously, I run courses for NCA that are specific only for, and they don't cover any other OSCE other than this one. And what I have taught in the past has been what's shown up in the exam. There's never been anything outside of what I've taught that has come up in the exam. So I can't direct you anywhere else. You can use various sources, of course you can. There are various online videos that you can watch about how to perform cardiovascular exams and how to perform venipuncture and practical procedures, etc. That's fine. You can watch those videos and you can get a good understanding of most of the things required for the exam. But what I give, particularly for the 5 days where I train you, is what you require for your exam. Okay, and nothing out, well, maybe more, but certainly not less. Okay? So how to prepare? I would say probably the course is the single best method of gaining the knowledge. But how you prepare yourself, how you practice is amongst each other. Okay? Learn and then go practice. For example, the mannequins, they need to be practiced on. You can't just go to the exam knowing how to do venipuncture but never seen the arm before, or the catheter, or the arterial blood gas. You have to practice these things. Clinical examinations, you have to practice these things on each other. Okay. And now is what? We're coming up to September from tomorrow. There is about 2 months before the exam. This, for me, is the optimum time to prepare for an OSCE. 6 to 8 weeks is the optimal preparation time for any OSCE. Any OSCE in the world. That's the number. That time frame of 2 months is key. You spend any longer than that, you're going to forget things. Any shorter amount of time than certainly 6 weeks, again, you're not giving yourself the best possible chance of succeeding. So preparing now until the exam is your best bet. Yes, I'm sure people have got other commitments, other exams that they have to sit, and I appreciate those difficulties. I know there's an overlap between PLAB 1 and NCA, and I've heard the same thing for the past few years now. Unfortunately, this exam requires as equal a preparation as any exam that you're sitting. Okay. We've talked about this. So in many stations, you'll be talking to a simulated patient. These are professional actors, so you're familiar with this. Most of your patients in your exam are simulated actors or mannequins. Okay, Very rare, maybe one, maximum two, will be a real patient. Okay, for the chronic patients, clinical examinations. So prepare, know what to prepare, and then practice it with each other until it becomes not a script. I've never taught in a way where you learn from a script, because if you learn a script like an actor does, for example, for a film, then if suddenly the other person, which is the patient or the examiner, goes off script, you're lost. My role is to, of course, teach you what comes up in the exam, but how to approach each station rather than just giving you doctor, patient, hello, my name is John, hello, my name is Dr. Singh, whatever. No, you've got to know how to approach each of these core clinical areas of competency so that no matter what comes up in the exam, you'll be able to handle it. No matter if the patient goes off script slightly, you will handle it. Okay, and often they can. These patients haven't come on my course. They don't know what I'm teaching you. Yeah. So they can slightly go off course, but you have to be able to adapt, be flexible, be dynamic, not be rigid and, oh, I've learned this from from a book and it has to be this way. No, it does not have to be that way. Okay. Patients don't come as scripts. They come as open books, and they can be as flexible as they need to be. Okay. And you have to join them in that. You have to, it's a dialogue. It's not a script that you have to follow. Now, pass mark. This is once you've done the exam. Okay? The pass mark, let me take you to this a sec. This was the days when there were 16 stations. Let's just say that we stop here at 12. Okay? Each station has a preset pass mark. Okay? A preset pass mark. And they are set by what is known as this method. Let me try to take you back a second. The Angoff method. Now, you don't need to know the complex science or mathematics behind borderline regression. It's not important for you to know that. But what's important for you to know is what Angoff method of marking stands for. It stands for the following. You have 12 stations. Each station is looked at by a group of experts, consultants, if you like, in that particular area of medicine. And those consultants or those examiners decide what is the mark, the percentage, the amount required to pass this skill by the minimally competent doctor. Minimally competent doctor. Okay? Not the greatest doctor, not the greatest surgeon, the most minimal competent. He has to be competent. Anything less than competency is a fail. He has to be competent, but to pass, it only has to be minimal competency. This is important for you to understand, because if you go into the exam thinking that with the pressure that I need to pass everything, you don't. If you look at the scores, and I'll tell you exactly how each station's marked itself, 15. 15 out of what? 15 out of 25. 13 out of what? 13 out of 25. Okay, all of these are out of 25. So you look at the pass marks, none of them are even close to 20 or close to 25. So you see the gap between passing and getting 100%. It's not required in any station. And it's not how hard a question is. It's not comparing you to John, to Samantha, you're not compared to each other. This is already preset before the exam by that panel of experts. for each station, what is the pass mark for the most minimally competent doctor? And to be minimally competent, you have to be safe. You have to be able to take a history safe enough so as to not miss anything serious. You have to, again, examine a patient minimally enough to not miss anything serious. You can't prescribe dangerously because you're not minimally competent. You can't do a practical procedure where you're hurting a patient because, again, you're not minimally competent. Okay, so Angoff method is not just for OSCEs, it's for almost every exam. They use this borderline regression, which says that the minimally competent individual requires this number to pass this particular question, or in your exam, station. Okay, and that is never 100%. Read the last line. Neither you nor the individual examiner will be told the pass mark for a particular station in advance. Nobody knows. That removes any preset notion in the examiner that this candidate needs this number of marks in this station to be able to pass. Oh, I like the way they look. I'm going to, if the examiner knew what the number was, they could get you to that number. But because the examiner doesn't even know what the pass mark is, they have to mark you as objectively as is required by the UK Foundation Programme Office. That's why they call it objective structured clinical examination. Okay, you will certainly not know the pass mark, and the examiner 100% will not know the pass mark either. Okay, just remember that it's the minimal competent doctor passes the exam. If you are better than minimal, you passed. Okay, I don't expect anyone to be less than minimal. Okay. Results and feedback. So this year, the date is 27th of November. So you will get your outcome for the clinical assessment by the 27th of November. You'll get a written report analysing your performance on a station-by-station basis. Okay, so they'll give you feedback for what you've done right in the station, what you've done wrong. The reason for this is if you pass, you don't care. Okay, you don't care, or well, you should care, but most people won't care because they passed. If you fail, you can at least see why you failed a particular station. That's why they give the written analysis back to you. Now, you've got to understand that the examiner has an iPad. They've got a checklist. They're checking things on the list. Have you done this in a particular logical sequence? And if you have, you pass the station. Okay. And at the end, they give you a paragraph, sometimes a short one, sometimes a long paragraph about your written report analysing your performance on that station. Okay. After each station, you'll get a written report. Well, even if you fail or pass, you will get a written report for every single station. Now, they're typing away. So obviously, some older examiners are not going to be able to type up really long paragraphs because they only have 1 minute. They only have a few minutes really to write this for you. Okay, you've got to understand that. And they can't come back to it at the end because they're examining so many different people. It's not going to happen. So they have to write it while you're in the task, in the station. Okay, so you will get a written report on your performance at the end, and this usually comes out on the 27th. Okay, and I've showed you here these pass marks. This is what you get on the actual written feedback itself. This is the front page. Okay, so these are the pass marks for each station, and then you have a breakdown of each of the stations, giving you your marks. And I'll show you exactly now how each station is marked. This is the overall mark to pass a station, but how do you get to that mark? I'll show you. Look, this is a feedback. And this was prescribing, safe prescribing, medication history and safe prescribing. This is candidate John Smith, candidate number 1, 2, 3, 4. Every single station is marked in the same approach. Okay, every station. You have 1, 2, 3, 4, 5, 6 things that you're marked on. These things that you're marked on obviously are adapted to the actual station. So for prescribing, initial approach is the same for all stations. This doesn't change, okay? Initial approach. These next few, obtaining details of medications, writing up prescription charts, safe prescribing, building and maintaining relationship, these will alter depending on the scenario. So for example, if this wasn't prescribing and this was history taking, then this, and this will change. For example, initial approach will be number 1 still. This may be data gathering, diagnosis, investigations, management. So these will change. The examiner will have these. You won't have these, obviously. The examiner will have these. These are what they're marking you against. And each one of these is marked out of a maximum of 4. Maximum of 4. So if you see the initial approach, the next few, depending on the station, you get 20 points here. Okay, 4, 4, 4, 4, and 4. That gives you 20. Now, the global mark is the examiner's overall judgment of you and your performance. And that's marked out of 5. So the maximum number of marks that you can get for your exam is 25 per station. That's why I told you when you go back, the pass mark is never 25. It never will be 25, even if the station is an easy station, because it's not marking the greatest student. It's marking the minimal competent student. So the pass mark set there, your aim is 25, but the pass mark is the minimum. Okay, remember that. Maximum 25, minimum is whatever the examiner wants them, not the examiner, but the panel of experts preset the pass mark to be. So the global mark is marked from 1 to 5, and it just depends upon the greater the number, the greater your overall performance. Now, what I've read before, and this is from the UK Foundation Programme Office handbook itself, is that you can sometimes score very good on the global mark, and even if you score very poorly on the station, or vice versa, you may score very good on the actual station itself, but very poorly on the global mark. That's not going to happen in your exam. I have read, of these results, I have read, oh, God, I've lost count, at least 500 of these. I've read so many. And that correlation is never, ever there. Okay? If you do well in the station, your global mark is high. If you do poorly in the station, your global mark is obviously low. Okay? Your aim, nobody goes into the exam with an expectation to be a minimally competent doctor. If that's your aim, I would withdraw from the application right now. There's no point having a mindset of being a doctor that is minimally competent. There's no point. Even if you've taken 10 years away from medicine because of health commitments, because of financial commitments, because of family commitments, there's no point going in an exam trying to be minimally competent. Your approach is to be the best that you can be. So your aim is always, every station, 25 out of 25. Obviously, if you don't achieve that, that's fine. The overall aim is just to pass. Yeah. But if you go in with the thought that I want to pass everything, and you prepare yourself well enough, then passing the exam is going to be nothing but a byproduct of that preparation. Okay. So just focus on this page. Understand that every station is marked like this. You have 5 elements to the task, and you have 1 global mark. Each of the elements is marked out of 4, and the global mark is 5. And here's the feedback that I was talking to you about. See, must be completed. There's an expectation of the examiner to complete this. So for example, this one for the safe prescribing, need dosage times for antibiotics, need signatures and name, need to omit atorvastatin as interaction with clarithromycin. There you go. Okay, so there's the feedback that the candidate received. Now, if you add these up, so 4, 7, 10, 13, 16, 20, so that 20, then you go to the corresponding station, okay? So for example, this was number 1, okay? And you go back to the front. Oh, what's going on here? Oh, this is where technical difficulties happen for no reason. Here, go to number 1, pass mark was 15. Candidate passed, despite having negative feedback. Still passed. Okay. Anyway, what does that 1 to 4 mean? Or 0 to 4, sorry. The marking scheme for each question is divided into 5 subsections. We've talked about that. Okay. For each subsection, examiners were looking for elements that comprise a skill in that particular subsection, which means, for example, for BLS, take basic life support, for example, initial approach, danger, response, airway breathing, compressions. Those may be the subsections that you're marked on. Okay, it just depends on the skill and the task. If you sit there silently and say, you know what, I don't know anything about cannulation, so I'm just going to sit here and just rest for 10 minutes. 0. If you do very few things, you score 1, half the elements. And again, how are these judged? There's a checklist. So they can objectively see on the checklist how many ticks do you have against the relevant elements of that skill. And the more you use, the higher your score in that subsection. The aim is for 4 to use all elements of that particular subsection. So for example, if one of the subsections for BLS was chest compressions, do you know how to perform the chest compressions? Do you know where to put your hands? Do you know how fast to do it? Do you know how deep to do chest compressions? Yes, then you score 4. Or if you only knew how to do the chest compressions but didn't know the rate and depth, then you may only score 1 or 2. So it just depends upon how much you perform for each of the subsections for your mark in each respective one. Okay, so this ranges from 0 to 4. And as I said, the next slide should be the global mark. Okay, the global mark is from 1 to 5. Okay, clearly not competent, not quite competent, just competent or minimally competent, clearly competent, and excellent. This is the objective opinion of what I should say. Well, that's a bit of a contradiction. It is what the examiner considers in their professional judgment about your competence in that station. Not the whole overall exam, but in that particular station. And this is why OSCEs were generated in the first place. This is the reason why OSCEs were generated, is because even if examiner number 1 was a total nightmare, let's just say he was a nightmare to everyone, there's no way that examiner number 2, 3, 4, 5, 6, up to 12 are all going to be nightmares. And that's why OSCEs were developed. So you're now getting objectivity from a large group of people examining you. Okay? But what I will tell you, and I will tell you with confidence, that for this exam, I promise you that all the examiners, all of them from 1 to 12, want you to pass. All of them. I don't care what you think about the examiner on the day, whether you think that they looked at you with disgust or dismay, or they were happy, smiling, laughing with you, it does not matter. They have a job, and the job is to ensure that you are objectively assessed, and if you are minimally competent, that you receive the marks that are just for you, but they will never, ever draw any prejudice towards you. They will never mark you based on your appearance or anything else of that nature. Not in this exam. I'm 100% certain of this. Okay, I can tell you that with absolute confidence. If you are good, you will receive a good. If you are poor, then you will receive a poor mark, which means that you fail. Okay, it's as simple as that. And just a very few words about this because I'm hoping that this doesn't happen, but unfortunately it does. Okay, every year some people fail and it happens. So if you don't pass, then there is an appeal process. I have, for this exam, unfortunately never seen anyone be successful at an appeal, not for the NCA. So it's important for you to make sure that you are the most prepared that you can be with the information that you can gather from whatever source you may use, whether that's me, whether that's somebody else, whether that's yourself, whether that's just from your colleagues, whatever it may be, you have to be the best prepared that you can so as to prevent this from ever taking place. Okay? But there is an appeal process that you have to submit in writing, explaining your grounds of appeal. But just know that if you came to this stage, it's unlikely that you'll be successful, and unfortunately, you will be withdrawn from the national process. Let's have a look at this. Okay, just to put some, I guess, some positivity back into the room. This was in 2020, and most years are the stats are about the same. 160 applicants were required to undertake the clinical assessment, and now it has increased from that number. Okay, it is more than 160. Certainly this year is more than 160. Okay, of the 160 applicants required, 121 paid for the assessment, and for some reason 5 people didn't turn up or whatever. 116 actually sat the assessment. Okay, so there were a few that sort of dropped out. Of the 116 who sat the assessment, 91 passed and 25% failed the assessment. So you can see that the pass rate of 20, and it's been very similar every year, is about 78% to 80%. That is quite high for an OSCE. Okay, that is quite high. If you compare that to PLAB 2, that is a lot higher than PLAB 2. Okay, so that's something that you should be reassured about, that the actual number of people that pass is pretty high. And I want to tell you one other thing. Everyone can pass. Every single person, every single candidate that sits the exam can pass. You're not in competition with anyone. You're not competing with your next door neighbor who's on station 2. You're not competing with anyone. You're not competing with your classmates or your group. No one. All of you can pass because the exam is measured by minimal competency. If all of you have that minimal competency, all of you pass. Okay, so just remember that. But obviously, there are people that don't reach that. I would say, from my experience, the number one reason that people fail this exam, number one reason is communication. Okay, poor communication skills. That's the number one reason. Medical knowledge is fine. Most people have the medical knowledge enough to pass the exam, but the communication skills are poor. You need communication in almost every station, whether that's history, counseling, examinations, practical skills. You need it in all of them. Poor communication is the number one reason. The second is management skills, which again, because if you don't know what to prepare for, you don't know how much extensively that you should read about different things. So clinical management is the second most common reason why people fail. So remember that communication skills have to be very, very up to scratch to be able to get through this exam. And that just doesn't mean just spoken English. It means the way in which you speak English as well. The words that come out of your mouth have to be understood by patients, have to be understood by examiners for you get your knowledge across. Okay. Further reading I've put here, yeah, that's fine. You can go through all of these things. That's absolutely, GMC outcomes for these are things that the UKFPO recommend reading, not me. Okay. They are useful links, obviously, knowing the BNF, knowing NICE guidance, knowing GMC good medical practice. These are all, if you had a long time to prepare yourself, yes, all these things are important. However, I would say that the number one best method now at this stage is to, even if you don't attend the course, at least know what is required for the exam and just focus on those things alone. Okay? Rather than reading all of these things. It's too much. So I will open the floor to any questions now. You can just type them in, or actually what you could do is, if you raise your hand, if that option's available, then please, by all means, you can ask any questions that you have. Let me see if I can unmute you. You can unmute yourself now if you wish to. How would initial approach be? That's a good question. Initial approach for each station is simply the introduction. So, hello, my name's Karam. I'm one of the doctors working in such and such a department. For example, I'm working in A&E. Can I start off by taking your name and your date of birth, please? And they'll give you their name, they'll give you their date of birth. Okay. What would you like me to call you? You call me Sarah. Sarah, how can I help you today? That's your initial approach for every station. Or if you're introducing yourself to a colleague, again, the initial approach is simply introducing yourself, clarifying your patient's identity and the reason as to why you are there today, or why they've come in today. That's all it is. It's as simple as that, the initial approach for each station. Or if you're dealing with an examination station or a practical procedure, can you explain the examinational procedure? Can you obtain consent? Can you offer a chaperone if necessary? These things will constitute initial approach. It just depends upon the particular task. Good question. Is there a minimum amount of stations that you must pass for the NCA? So, historically, in the last few years, 8 has been the minimum number of stations that you require. 8. They won't tell you that. You won't get that information anywhere unless they perhaps email you that information this year. But I've seen feedbacks with my own eyes. People have passed less than 8 stations and still pass the exam. I've seen those feedbacks. I've counted them very carefully. And some people, and there's not many, by the way, that have passed with 7 stations. But I would say if you aimed for minimum 8, you'll get through the exam. Okay? But I have seen people pass with 7. Any other questions, my friends? Total number of stations is 12. Oh, sorry. Yeah, so that's a good question. What if we are not able to complete the history taking or any station within 10 minutes? That's a great question. The examiner is a friend of yours in the station, okay? In all 12 stations. If you are doing really well, as in your history taking is following a very logical, systematic, organized format, the examiner may even stop you before you've completed your history and say, that's enough. Now turn and talk to me and answer my questions. Okay? So There is always 2 to 3 minutes allocated to the examiner before each station ends. So if you're going on too long with the history, just understand that the examiner will stop you. And if they're happy with what they've heard, you can still get full marks. Okay, even if you haven't finished the history taking, it doesn't matter. You can still get full marks for that. So they understand that you're under time restrictions. You don't have to finish stations within time to still receive the marks. If you're doing things in a nice order, okay, and everything's logical what you're saying and sensible towards, for example, the presenting complaint, the examiner will stop you and say, look, let's talk about these things now. Counseling. There is no end to counseling stations. So even if you're still talking at the 10-minute mark, that's fine. Just stop when the bell goes off and leave. Even with that being said, the examiner will stop you anyway. Once they've heard enough, once they've got enough from you, they will stop you and they'll ask you some questions regarding whatever communication station you're doing. Similarly with examination, if the examiner is happy that you've examined them quite systematically, even if you've got still some steps left, they may stop you and ask you some questions. But the only station that you have to perform the skill within the time frame is practical procedures. You have to make sure that you complete whatever clinical skill that has been asked of you within the time frame where you have to complete. It's venipuncture, you have to complete it within the time frame. Cannulation, ABG, you have to finish within the time frame. All other stations, I would say that wouldn't worry about the time at all. The 2-3 minutes that the examiner talked to you, this is including the 9 minutes, correct? It is. Yeah. Yeah. The 2-3 minutes is the examiner's questions as well. Yeah, so the cubicles are divided like with a divider. So there's a big sort of cardboard divider that is dividing. So if you, for example, if you take a little office room, a small office, yeah, very, very small office, with no doors, no windows or nothing, okay, just they're called dividers, okay, or like a curtain rail covering one cubicle to the other. And the front of the cubicle is open. So you can see the outside, yeah, or some of it's covered, but you won't be able to see other candidates because there are enough dividers to keep you away from other candidates. Okay, so 6 in one room, 6 in the other room, small dividers in between each section so that the candidates are kept separate. After history taking with the patient, do we simply tell the examiner our diagnosis and proceed to management, or do we need to provide reasoning for the diagnosis as well? Any questions the examiner will ask you will be very specific. They will then ask you, what is your diagnosis and what is your differential diagnosis? What investigations would you do next? Okay, what management would you put in place, etc., etc. So the examiners will guide that part of the discussion. You don't need to worry about the 2-3 minutes. Let the examiners guide you then. Last year, I attended this exam because of poor and rest. I am not able to make this exam. I don't know what that means, Rakesh. I'm sorry. Who else have we got? There would be no station that requires us to do both history taking with examination, right? They would come separately. So, good question. There are only 2 stations in your exam. I'm telling you this now, okay? You can remember this. There are only 2 stations in which you need to do a history and examination on. Only 2. They are chest pain and abdominal pain. Those are the only 2 stations in which you need to take a history and physically examine the patient in that station. No other stations. Every other station is either history or examination, but not a combination of the 2. Okay? Only chest pain and abdominal pain come as combined stations. Rakesh, because of poor sleep and rest, I mean to say, do you want to turn your mic on and ask me what you're saying? Because it could be an important point you're making here, if you're not too shy to speak.
Hello, hi. How are you?
I'm good, I'm good, I'm good.
Last time, because see, I just traveled from back to my home from India, and I just came to Manchester, and I haven't got any place to stay because of the Airbnb people just playing around me. And next day was my exam, and I haven't slept for the whole night. And once I entered the exam, that everything was messed up with me last
Yeah,
year.
yeah. Oh,
Because
well,
of
yeah,
sleep and rest, I was not able to concentrate properly last year.
yeah, of course. I mean, don't do, I mean, thank you, Rakesh. I'm sorry to hear about that. Don't do that, guys. That's a tragic mistake. You have to be well rested. You can't go to the exam tired. Okay. Listen, let me give you some advice. You're traveling from abroad, yeah? Make sure you come with at least a couple of days in advance. Just make it happen, even if it's expensive. Believe me, the expense of staying 2 more days in England or you doing the exam next year, there's a far greater difference in expense. Okay, so please make sure that you at least come, if you're coming from abroad, with this within a sensible time frame. Okay, stay in Manchester. Yeah, stay in a cheap hotel or Airbnb around the place. Get some rest. Okay, if you live in England already and you're traveling from England to Manchester, there are some people that went in the morning the exam. I wouldn't recommend that at all. I would not recommend that. I would recommend going at least the night before, resting. And another key advice I give, now most, it depends on you if you want to listen to this or not, is don't do anything the day before. Don't study the day before. Don't at least don't study the whole day. Don't be sitting there reading the day before, because if you have to do that, that means you were never prepared for this exam in the first place. If you require the last 3 hours to save you in the exam, there's no, you might as well just take the flight back home or go back to whichever part you've come from. There's no point doing the exam. Okay? Leave it. Day before rest, think about something else, focus, unwind, relax, go to the exam refreshed, ready. I've done every exam you can think of, every single exam from the USMLE to PLAB to NCA to GP exams to MRCP. I've done all of them and I've never ever changed my approach for any exam. Okay, so rest the day before, think about something else, take your mind away from it. Okay, and in the morning of the exam, go there with the trust that you've prepared the best that you can do. And don't do what Rakesh did, was fly in the day before and stay awake all night and try and do the exam, because that's never going to happen. Okay, you've got to get adequate amount of rest before the exam. What if you get your provisional diagnosis wrong, but include it in your differentials and doing your management according to your provisional, which is wrong? What would be the, yeah? So your diagnosis, it's never a diagnosis, by the way. It's a differential diagnosis, particularly for history taking. Okay, it's always a differential of two or three sensible differentials, and then the examiner will ask you, okay, so these are your differentials. What investigations would you do to confirm or refute, to include or exclude these differentials? Then you list out the simple bedside tests, blood tests, ECG, chest x-ray. You've got to understand that the exam is set at the level of FY1. So the investigations you do, the treatment that you initiate is going to be very basic. It's not going to be high level specialized things. It's going to be very basic bedside tests that you're going to order. Just remember that. Okay. So obviously, if your diagnosis is wrong and your management is wrong, then you're not going to pass the station. It's going to be very difficult for you to pass the station. You can still pass, by the way. You listen to this. If you get the diagnosis wrong, but your history was excellent and your management was a little bit off kilter because your diagnosis was wrong, you can still pass. You can still pass. Because I'll tell you why. I'm going to explain myself why. I talked to you about clerking patients, seeing lots of different patients. when you're in particularly the acute medical ward. You see lots of different presentations, and you have to discuss all these presentations with your examiner. They know that in real life, a lot of FY1s, a lot of FY2s, even more senior doctors get diagnoses is wrong. But as long as their history covered all the red flags, was a solid enough history, and the examination was good enough, you know, and the tests and treatment wasn't dangerous, that's fine. You're never ever always going to get the diagnosis correct in real life. I don't always get it right. It's not going to happen. Yeah? So they understand that. So you can still pass. This exam is not hard and fast with its rules of passing and failing. Okay, that's why you've got so many different subsections to try and get you enough marks to, to overcome the pass mark required for each station. But obviously, try and get the diagnosis correct as much as you can. Are there stations with detailed history and some with focused history, or are they all focused history? Okay, every history taking is always a focused history. After saying thank you for all the information, now I'm turning to my examiner, to the patient. Do we wait for the examiner's questions, or do we simply start by saying, ideally, after taking history, I now need to examine the patient's cardiovascular system and vital signs before proceeding to management plans? It's a good question. Don't worry. Stefan, my advice to you is don't worry. The examiner is going to either stop you, or as soon as you've said thank you, they're going to talk to you. Okay? You don't need to worry about how to start speaking with the examiner. They will speak with you. Okay, they have set things that they need to ask you, and they will ask you. Okay? How might initial approach be marked in the prescription station? Nowadays, because there's no patient in the room that you're speaking with, there is no real interaction with any physical patient. I guess the only thing that you can do in the initial approach is to ensure that the prescription is completed with all the very basic information on there. For example, that the patient's name is on there, their date of birth is on there, the hospital number is on there, the allergy box is on there, and it's been ticked and signed and completed. So you need to verbalize these things to the examiner first before reviewing the rest of the prescription. So that will be the initial approach in the new prescribing station. What are the data interpretation stations that can come possibly? Good question. So there's only two. There's only two stations where data, no, there's three. There's three stations in which data interpretation can come as a station, but not by itself. The first station is arterial blood gas. ABG is the performance of the ABG. Then the examiner will give you an arterial blood gas at the end to interpret. So that's where data interpretation comes in, a practical skill. The second is ECG. You perform the ECG on the patient. The examiner will then give you an ECG to interpret step by step. And the third place is the chest X-ray, in which you take a history for cough or shortness of breath. The examiner will show you a chest X-ray. You have to systematically talk through the chest X-ray and then come up with a diagnosis at the end. And actually, the fourth for data interpretation is venipuncture, where you do the venipuncture. The examiner will give you some blood result findings, and you have to interpret the data on the blood results. Annie, you've got your hand up. Would you like to ask your question?
Yes, I don't know if you can hear me.
I can hear you, yes.
Yes, you mentioned something about when it's time for preparation, you have to focus on NCA only. What about in the case of people who are, for example, practicing? You were talking mostly about PLAB 1 and NCA, but what about those who are preparing for both NCA and PLAB 2? Since there are differences, I don't know if it's notable differences or slight differences that people should take note of. But how, or is there a way you advise people to tackle the exams with their similarities and differences? If there's not much of a huge gap between both exams, since they're a bit more, they're both OSCE exams.
That's a good question. So do you have PLAB 2 coming up soon?
So my PLAB 2 is after my NCA, about a month after.
Okay, then
It was supposed to be before, but I moved it for after to give NCA preference.
Yeah, that's fine. Look, NCA is basic medical knowledge. Okay, it's not enough to pass PLAB 2. it's not enough. So if you prepare for NCA well enough, it will give you a foundation in which you certainly need to build on for PLAB 2, because PLAB 2 is set at a higher level. It's a whole year later. It's the entry point of FY2. So there are, again, if you're preparing through a course-based approach, then you'll see that the things that are tested in PLAB 2, although they follow the same structure, history, communication, examinations, practical skills, it's still an OSCE. But the things that they test, the communication things they test, the ethical and legal issues that they test, the obs and gynae, the peds, all of these things appear in PLAB 2. So there's a larger number, the curriculum is wider for PLAB 2 than it is for NCA. But if you focus on NCA now, you build a good enough foundation through your preparation through NCA, then I don't know what you're going to do, whatever your plans are for PLAB 2 to consolidate that extra knowledge, whether that's going on a course, then all you're doing is you're building on a firm foundation, because NCA is the basic foundation required to build upon for the rest of your career, because it's the entry point, if you like, FY1. Then you have to build on that with more knowledge. So I would say for you now, both exams are difficult. Obviously PLAB 2, sorry, you only have a set amount of time to pass before you can. I think if you're doing it this year, PLAB 2 still, then you might have another attempt if needed. But ideally, you want to pass everything the first time. So put all your efforts into NCA, all of them, okay? Because a lot of that information is translatable into PLAB 2, but then you will still need to do specific PLAB 2 training once you're done with the exam. If you've got a month apart between the two, that's absolutely fine. If you only had a few days apart, it'd be a little bit more difficult. Then you'll have to try and cover stations for both PLAB 2 and NCA in tandem, because at the end of the day, they're still OSCEs. You just have a larger number of OSCEs to study, that's all. Okay, Annie.
Okay, thank you.
I have a very similar question. Sorry, I tried to raise my hand, but I don't know where the button is. I just couldn't find it. I will probably be sitting the Press 3 for Ireland and the NCA all within a span of like 4 or 5 days. So I'm just wondering what your take is. What should I focus on? I have passed the PLAB 2, by the way. I'm done with that.
Okay, so when's your Press 3? November the 1st?
Yeah, if they approve my post, because last time there was no space for people without refugee status. So fingers crossed it actually works this time around.
That Miss Lena, you must know me very well then, yeah?
Yeah.
Because you're fully aware that I teach Press 3 and I've been doing so for a very, very long time. So, and I will be doing that in mid-October as well, because I understand that there is an exam for November the 1st. Now, that's a difficult question, because NCA and Press 3 they're different, because you've got the data interpretation aspect to the exam to cover as well. I will talk to you after, Lena, okay? I will speak to you after about this. How best.
Thank you.
Okay, only because I want to keep this UK based. Ireland, I keep separate to this, but I will speak to you personally after about this, okay?
Thank you, I appreciate it.
I remember you, Lena, from last time, actually.
That's nice. That's nice to hear.
I do remember you. I'll speak to you shortly, okay? So Sarah said, when doing examination stations, do you state the abnormal findings like a running commentary, or do you stay silent until finishing the examination and then verbalize findings to the examiner? Excellent question. Examination stations require a running commentary, because if you run out of time at the end, then the examiner will not know what to mark you on. So how I would approach actually most OSCEs, not just the NCA, is that when you're doing a cardiovascular exam, you say, for example, on general inspection of the patient's hand, there is no evidence of clubbing, Janeway lesions, Osler's nodes, whatever it may be. And then the examiner will hear that. So the examiner knows what you're looking for, what you see, and what you don't see. So do it as a running commentary. Okay? Don't leave it at the end to summarize your findings. Again, the examiner will stop you at the end and they will give you a chance to answer any questions about findings. Okay, I told you for cardiovascular, there are findings. For respiratory, there are findings. Even for simulated actors, there may be findings. They can draw ulcers on the feet, for example, in diabetic foot. They can draw or have a picture stuck on there, or lots of different fancy things that they can do. Okay, so that's why you have to actively look for things on clinical examination. You can't just, that's why I say a script, although a script is important, you can't just do the script blindly. You have to look for things because there may very well be things present on clinical examinations. There was a scar mark of a cabbage. There was a pacemaker. There was a mitral regurgitation murmur. There were lots of things in the exam that you had to pick up. And if you don't pick up those things, again, you can still pass. For the NCA, surely you can still pass, providing that your sequence was quite structured and logical. However, obviously your marks will come down if you don't get the positive findings. Will acute stations be on a SimMan or a simulated model? So there's no SimMan in the exam, okay? You don't have a SimMan like you do in PLAB 2. It's not like that in the exam. It's done on a model. However, the examiner will give you all the findings, okay? So don't think about SimMan for NCA. There is no simulated mannequin. It is all findings given by the examiner, and you're just going through the ABCD approach to the examiner, essentially. Okay? We know SimMan. I recognize that voice. That sounds like my little son. That
Oh my God, I'm so sorry.
It's okay. That's not, I might have to put, yeah. That's my little baby, by the way, guys. Don't know what he's doing online, but yeah. Does the 5 days package include the notes? Yes, so everything's in 5 days, everything's included. And by the way, those 5 days covers everything for the exam. You don't have to go and do anything else, geeky medics, whatever else. That is it for your exam. You study that, you pass, the exam's done. Okay, and so this is one exam. And Ireland, Press 3, I'm very, very confident about. I've been doing it for too long now to say anything otherwise. Yeah, more than enough. If I've done PLAB 2, are there things that can be done in PLAB 2 as an FY2 but can't be done as an FY1 in the management? No. If you say more in the management than necessary, that's fine. Okay, but you can't miss the basics out. So let's say that your knowledge from PLAB 2 is a little bit more than the level of an FY1. That doesn't mean that you can miss out the most basic tests that are required. So saying more is fine, but you have to make sure that all the basic tests, the basic managements are put in place before you say anything beyond that. So that's fine. Will you be providing us with practice materials, for example, sample history taking? Yes, yep. The notes cover everything. There's videos, the videos cover everything. And obviously the course itself will cover absolutely everything. Would you say your course has enough information for us to pass each competency? Yep, I've answered that. That's fine. You don't need to do anything else, okay? If we have any more questions, where do we send them? If you have any more questions, if you're not already in the group, then you can be added into the study group. It's going to get a lot more active, obviously, as the course approaches. If not, you can just email me, and I'll leave the email address below for you to be able to email us on, okay? About the exam, the course, or whatever it may be. Do I have to be in the UK for the 5-day program? No, you can do it online. And is a month enough to prepare? I would say a month is enough. You should leave about 6 weeks for the exam. It's more than enough to prepare for this exam. Is there a point of reference we should use for the examinations? You can use Geeky Medics. They're pretty good. The Geeky Medics are pretty good, to be honest. If there are bandages on the patient's feet and diabetic foot, do we have to take them off? Yes, you do, but there won't be any bandages on anyone's feet in any of the stations. If they have an ulcer, it will be drawn on, or there'll be a picture attached onto the patient's foot for the exam. Okay. Any other questions, guys? Very good questions you asked me. They're all very relevant to the exam. If not, I think I will love you and leave you for now. Okay, we've just
Hello, Dr. Karam. Sorry, colleague. Thank you so much for the session today. It was really helpful. It's just that I wanted to know about the accommodation in Solihull if we want to come for the practice sessions.
accommodation. It's a small town just by Birmingham, so I'm sure there's plenty of places to stay, Airbnb, etc. The actual so how I broke down the courses, the 5-day course, there's 2 days online, 29th and 30th. Then the first and second is in a big conference room because there's quite a few of you coming. So that's in a larger hall just to accommodate everyone basically. And then the practice room, I've actually booked a hotel, the Regency Hotel, which is in Solihull, where all the mannequins will be. I've got a big classroom there to separate all the stations, etc. So that will be open 24/7, so you can practice in there as much as you want up until the exam, obviously depending on how long you can stay in Solihull for.
All right, and like I'm asking about any accommodation nearby for people like us who are traveling through other cities, because from 6th of October till 1st of November we can practice, right? So if someone wants to stay for a day or two or a week, if there are any
I'd say the Regencies are pretty. Do you mean a hotel? Are you talking about
a hotel or an Airbnb where we can stay if we want to come for like a day or two or a week?
Right. Okay. I would say the hotel's probably cheap. It's about 50-60 pound a night, I believe. It depends on how much you want to spend, obviously. Yeah.
Right.
But it's not that expensive. I'm sure there's other places. There's a few other hotels around which are very cheap and reasonable as well. But I don't know about Airbnb because I don't use it myself, unfortunately. But I'll say the Regency is probably the best because the practice center's there, so it's in the hotel. So if you want to do it there, you can stay there probably.
All right, lovely. Thank you so much. And one last question: is it okay if we ask what's your age instead of a date of birth?
The gold standard for OSCEs is date of birth because you can get many patients of the same name and the same age in the UK. So it's important. So John Williams, who's 92, you can have so many of them. So I think date of birth is probably the goal. So if you miss and you say age, that's fine. You're not going to get marked down. But I'd say try and remember age if you can.
All right. Thank you. Thank you so much.
Thank you. Okay, so any other questions, guys? Or shall we wrap up for today? This recording will be available for you so you can go back and obviously there's a lot of information about the exam. You can go back and read it, listen to it all again. And just prepare well, no matter what you do, course, no course, you do it yourself. You don't have to do a course, by the way. You can study this exam by yourself. You just have to know what to study. Obviously, the course will give you that guidance. But if you don't want to do a course, then you have to make sure that you at least find information about what is likely to come up in the exam. I will put out all the past questions for the past 10 years in our group, so you can have a look at look at exactly how exams have come up in the past and what stations have shown up, and you will see yourself how repetitive the exam actually is. There are only a set number of stations that the NCA exam covers. There are not many, I promise you. Compared to PLAB 2, it is probably not even a quarter of what PLAB 2 covers. It's about 25%. I've taught PLAB 2 for many, many years. I'm very familiar with the differences between the two. NCA is about 25, maximum 30% of what PLAB 2 covers. Okay? So
I'm sorry, could somebody just add me to the WhatsApp group because I'm not part of it, and I also don't know when the live course is. So
I would do.
Thank you.
Would do, yeah.
Oh, me too. I'm not in the WhatsApp group.
Just message me, okay? So all you're gonna do, just throw me your number, message me a number, say hello, and I'll put you in, okay? But yeah, just keep studying, guys, and keep preparing. By the way, have they emailed yet to make the payment for the exam? Has that actually happened?
No, not for me at least. No.
Right, okay. Not yet. Okay. I think that will be coming up very soon. Probably the first or second week of September. You will have the payment link. Make it straight away and get yourself booked onto the exam. Okay. But God bless you all. Okay. And I wish you all the very best. I know how important this exam is for all of you. So I do wish you the best on your journeys. If I see you again, I see you again. If not, I wish you all the best. Okay. See you soon.